to start the fourth Interim Joint Committee on Banking and Insurance of the 2021 interim session. We do have a pretty full agenda this morning, so I want to get started on time, and hopefully we can finish up here within about an hour and a half. Before we call the roll, do we have any members who need to recognize any guests in the room today? Seeing none, Madam Secretary, if you would please call the roll.
Senator Rocky Adams. Senator Alvarado.
Present in the room.
Senator Gerdler. Senator Howell.
Present in my district.
Thank you. Senator McGarvey. Senator Parrott. Senator Schickel. Senator Smith. Senator Storm.
Present remotely in my district.
Thank you. Representative Bentley. Representative Fisher.
Present in my district.
Thank you. Representative Flannery.
Here in the room.
Representative Frazier.
Present in the room.
Representative Gooch. Representative Hatton.
Good morning. I'm present from my district.
Thank you. Representative Kirk McCormick. Representative Koenig. Representative Cole Carney.
Present for my district.
Thank you. Representative Lewis.
Present in the room.
Representative Lockett. Representative McPherson.
Present in the room.
Representative Meredith.
Present in the room.
Representative Roberts.
Present in the room.
Representative Santoro.
Present in the room.
Representative Smith. Representative Stevenson.
Present in the room.
Representative Upchurch.
Present in the room.
Representative Westrom. Co-Chair Carpenter. Co-Chair Rowland.
Present in the room as well. We do have a quorum at this time.
Can you hear me?
Yes.
This is Senator Parrott. Did you get me?
Yes. Are you in your district?
Yes, ma'am.
All right. I got you down. Thank you.
Thank you.
Thank you. We do have a quorum, so I will entertain a motion to approve the October 5th, 2021 minutes. I got a motion for Representative Lewis. Second, Senator Alvarado. All those in favor? Aye. And minutes are approved. We do have a pretty full agenda, and I think we'll just go with the order. We'll go in order as it's printed on the agenda today. So first, if we have Commissioner Clark and the folks at the Department of Insurance, are you online with us?
We are, sir.
Good morning, Commissioner. It's good to have you with us. If you would introduce you and your staff, and the topic this morning will be an update on mental health parity laws.
Thank you, Mr. Chairman. And yes, I'm Sharon Clark, the Commissioner of the Department of Insurance, and I have with me Sean Orm, who is an Executive Advisor with the Commissioner's Office. And I will try to make this brief, Mr. Chairman, in respect of your time. But the Mental Health Parity and Addiction Equity Act of 2008 generally provides that the financial requirements such as co-pays, co-insurance, and treatment limitations imposed on mental health substance abuse disorders cannot be more restrictive than those provided for medical surgical. These are referred to as quantitative treatment limitations. And really, if you think of those, they can be measured numerically, such on the number of office visits or co-insurance or what have you. But the Act also prohibits the health plan from imposing more restrictive treatment limitations on the mental health substance abuse disorder. The federal government has created an online self-compliance tool to help explain the requirements and to help the state regulators in implementing this. However, in December 2020, Congress amended the Act, and this amendment requires the insurance companies of health plans to perform and document their comparative analysis and also a report to the Department of Insurance. This self-compliance tool is being updated in the near future. We're also working on these tools through the National Association of Insurance Commissioners. The recently enacted House Bill 50 essentially adopted the language of the NQTL requirements of the Federal Act. The bill also has the same requirement for the health insurance companies to submit an annual report. So going forward, the department will be looking at ways to implement the requirements We are anticipating to promulgate a regulation, but again, we're waiting on this tool, and it is a very complicated tool that's going to be used by the various departments in trying to make this analysis. And we're working diligently on that, and we expect to meet all timelines. So that's a short report, Mr. Chairman, and if there's any questions.
Thank you, Commissioner. Do we have any questions on this topic from members of the committee this morning? Commissioner, you must have done a very good job. I don't see any questions at this time.
Thank you, sir.
We appreciate you being with us. Will you all be monitoring the rest of the committee and available should questions come up on other topics?
We will, sir.
Okay, thank you. Moving along to our next topic, it will be insurance coverage for the treatment of eating disorders. We have Melissa Cahill here. She is the chair of the Kentucky Eating Disorder Council. I'll let her come to the table, introduce herself, and the rest of the group who will be presenting with you this morning.
There we go. That better? All right, thank you. Thank you, Chairman Rowland. I am Melissa Cahill. I am chair of the Kentucky Eating Disorder Council. I have Dr. Andrea Krause here with me today, Justin Wallen, business manager of the Louisville Center for Eating Disorders, and Ruby Jo Labarsky. We appreciate your time today in allowing us to do this testimony. Our topic is mental health parity, which it's very appropriate, being that Sharon Clark just spoke, and eating disorder treatment in our state. All right, I'll wait for Justin to get our presentation pulled up. All right, you can just flip to the next slide. All right. Just to give everybody kind of a basis for where eating disorders are in the state of Kentucky. They are currently an epidemic. In the state, there are approximately 900,000 individuals diagnosed with an eating disorder, and of those, 29,000 are children. In our state right now, there are 0 acute care programs, 0 residential, and 0 partial hospitalization programs. So anyone diagnosed with this illness that needs a higher level of care than outpatient, they are required to go out of state. That is their only option. And individuals that have Medicaid in our state really have few to no options because not many out-of-state providers will work with Kentucky Medicaid. Eating disorders as an illness are they have a high mortality rate. I don't think a lot of people realize that. In fact, anorexia nervosa has the second highest mortality rate of any psychiatric illness, second only to that of opioid use disorder. They are really debilitating. The average time from diagnosis to recovery is about 10 years, and these illnesses often become chronic, and they're very costly to treat. Treatment costs on average around $20,000 a month. So the reason we are here is that the Kentucky Eating Disorder Council was created to address the serious nature of these illnesses and to really work on improving what Kentucky residents have to face when they are diagnosed with this illness. We are charged with prevention, early detection, education, and research, but I think the most important goal of the council is to provide more access to quality care for all Kentuckians. What we have found in our first year of work is that one of the major obstacles to providing this goal is the insurance companies. We have hit a roadblock. Insurance is preventing us from creating access for all Kentuckians for care. You can go back one slide, sorry. So what are some of the barriers that Kentuckians are facing when diagnosed with an eating disorder? First and foremost, there's a lack of providers that participate with insurance. There's a limited number of professionals that actually treat eating disorders. The demand is high for the services, and the supply of qualified individuals is very low. The review criteria used by insurance companies really doesn't accurately reflect what goes into treating an eating disorder. So often people are discharged before they're even medically stable or ready to move to a lower level of care. People are forced to go out of state for care, and that doesn't, even if it's in network, it doesn't account for travel costs, lodging, medications, labs, all the additional fees that go with treatment. And once they are discharged, they come back to the state of Kentucky and find themselves in the same position they were before they left, which there is nowhere to go for in-network affordable care to support their recovery. So why don't providers participate in network? The basic answer is reimbursement rates for mental health providers are so low they are unable to be in network with many of the insurers. So when someone goes to find care, they're looking for an in-network provider. They can't find one. They're forced to go out of network, which often delays treatment, limits the amount of treatment they can get or afford, and ultimately some of those individuals just don't seek care. Milliman put out a report in 2017 that basically did a nationwide survey of over 42 million claims, but they also broke it down by state. And just there are thousands of statistics I could share with you today, but I know time is important. One of the statistics that really rang true was that out-of-network utilization rates for mental health compared to that of primary care, on average, 5 times higher people have to go out of network for mental health care. They also analyzed reimbursement rates compared to primary care relative to Medicare, and on average, mental health providers in the years 2013, 14, and 15 received 29.4% less than their primary care counterparts. That's a significant number. So, limited number of providers, low reimbursement rates. Why is this happening in Kentucky when we have states surrounding us, Ohio, Indiana, Missouri, Tennessee, that all can offer these services? It's something we need to investigate. It's geographically challenging for a lot of Kentucky residents. We need to improve telehealth access for those areas that can't geographically access care. Very important. And managed care often does interfere with the course of treatment with premature discharges, sending people home with no step-down programs available. So that is where we are in summary, and I wanted to give Justin Wallen the opportunity to discuss this situation from a provider side.
Good morning. As you mentioned, my name is Justin Wallen. I'm the business manager for the Louisville Center for Eating Disorders. Is this one on? I'm the business manager for the Louisville Center for Eating Disorders in Louisville, Kentucky. We're the only practice in the state that is actually offering a higher level of eating disorder care that's covered by any insurance at all. Treatment of eating disorders requires some very specialized training, a lot of extensive education and evidence-based treatments, as well as continuing education courses. Our providers at the Louisville Center are masters and doctoral level therapists with this extensive training, and they require and deserve adequate compensation to actually remain and continue performing these services in the state. A little history of our relationship with insurance. We started our intensive outpatient program in October of 2017. At that time, we were out-of-pocket, self-pay only. We realized very quickly that we weren't going to be able to help a sufficient number of people, having to charge out of pocket. So in January of 2019, we were first able to get in network with a couple of insurance companies. Still the rates were insufficient to support a program long term. Since that time, costs have increased. So in early this year, we began renegotiating those contracts. It's 11 months later and we still haven't made any progress. At that same time, we also started looking into adding a partial hospitalization program. So that's a 6-hour-a-day program versus the 3-hour IOP program. Again, those negotiations haven't gotten very far in the 11 months since we started them. And at 6 hours a day, as well as all the additional costs involved with that, there's no way that that level of care is going to be accessible to anyone in Kentucky out of pocket. We've been prepared to perform these partial hospitalization services for probably well over a year now, and really the only holdup is getting a sufficient reimbursement rate to actually accomplish that. A little bit about our experience so far being in network for eating disorder. Higher level of care from a business perspective, it's just been very costly and frustrating. Requires full-time staff members to deal with them, sit on the phone with them all day. Every day we have outside vendors who have to supply our billing to them, and then it just involves significant therapist involvement that takes away from a lot of patient care. We also run into issues with last-minute denials where essentially the insurance company says they can't pay for another day, so ethically we can't stop seeing the patient, so we end up bearing those costs ourselves. Just from a patient's perspective, I think it's just a lot of uncertainty involved. There's always the risk of being cut off of treatment. We often find that a lot of these decisions to end treatment are arbitrary and made by people without any experience with eating disorders at all. And then just from a state perspective, I think this displays some serious issues with the power that insurance companies have over providers that are trying to offer this much needed care.
All right. Thank you, Justin. Dr. Krause?
Hi, my name is Dr. Andrea Krause, and I am a board-certified pediatrician. I practice hospital-based care through Norton Children's Hospital. I've been there for the past 15 years. For the past 12 of those years, I have actually been the physician that helps to stabilize our sick eating disorder patients that get admitted to the hospital. And so that's a unique position to be in. I would say that with what I do, that is definitely a catch-all. And so I see the failures that we have here in the Commonwealth of Kentucky due to lack of access. And there's two things that play into that. On one side of things, we do have some poor recognition out in the community by providers, whether it's primary care providers or whether it's, mental health therapists that don't have experience with eating disorders. So there sometimes can be a slow recognition of what illness is actually happening to this child. And then on the other side of things, there's also that poor access to appropriate care. And so as these delays occur for these patients, basically, further delays in treatment, the child is simply going to have a downward spiral. And that can be with worsening kind of behaviors and weight loss that goes with it. And so by the time they see me, they are near death. And so my job is to medically stabilize them. Next slide, please. So 2021 has also been quite unique in that we've had an almost twofold increase in the number of medically unstable eating disorder patients that have been admitted to Norton Children's Hospital. And that is on top of a year-to-year increase of about 20% per year for the past 10 years is the pattern that I've been seeing. I would say that these kids are sicker than ever. And I believe this is due to the lack of access and care in the Commonwealth. Our payer mix breakdown is about stable. Typically 60% of my patients that I see with eating disorders are privately insured, yet 40% are on Kentucky Medicaid. So currently the only option in the state that I have for any higher level of care for appropriate treatment for eating disorders happens to be with the Louisville Center for Eating Disorders. So additionally, insurance payers a lot of times do not seem to be aware of our published guidelines by the American Psychiatric Association, as well as the American Academy of Pediatrics regarding our appropriate levels of care and what fulfills the appropriate level of care for eating disorder treatment. I actually once had to have a peer-to-peer review explaining to an insurance reviewer that, in fact, failure to thrive guidelines, which would appropriately be for infants, is not an appropriate guideline to use for a teen eating disorder patient. So when kids are hospitalized for eating disorders, a lot of times they actually do fulfill criteria for residential care. And pretty much that is a conversation of telling parents they are going to have to seek care out of state for their child. And that does not go over well. So currently, the other thing to be aware of, that there is no out-of-state eating disorder residential facility that actually has an active Kentucky Medicaid number. There were 2 facilities, one in North Carolina and one in Florida, and those numbers have now expired. I feel that due to poor reimbursements, I suspect that those facilities are going to have no incentive to re-up their certification for Kentucky Medicaid. So basically, that is to say that any Medicaid patient that comes to me medically unstable is going to stay there for weeks, if not months, in the hospital due to lack of placement options. And of course, that is detrimental to treatment. I can weight restore a child, but ultimately to fix the psychology behind the illness is not something I can do at the Children's Hospital.
All right. Thank you, Dr. Krause. Ruby Jo?
Thank you and good morning. I'm Ruby Jo Cummins-Labarsky, and I truly do appreciate this opportunity today to continue to discuss the lack of resources in Kentucky to provide the medical care and the treatment to those individuals who are struggling with an eating disorder. I am the grandmother of a 17-year-old young lady who was diagnosed with anorexia in 2017 at the age of 13 while in middle school. I'm getting emotional and I apologize. I had not planned to do that. During these last 4 years, she has had 2 acute care hospitalizations, 2 partial hospitalizations, 4 residential stays, and continuous outpatient therapy and nutritional care. And as you've heard, Kentucky does not have partial hospitalization programs. Kentucky does not have residential care programs and very limited outpatient therapy. All 4 residential stays for my granddaughter were out of state. The residential care cost is between $1,000 and $1,500 per day, and the average length of stay is 30 to 90 days. Only 2 of the 4 residential stays were covered by insurance. One of the 4 providers could not come to an agreement with the insurance provider on the rates, and one provider was not willing to accept insurance from a Kentucky insurance provider at all. Residential care is a first step with weight restoration. It gets you on a path, hopefully, to recovery. The step down from acute care is partial hospitalization. And again, my granddaughter's had 2 out-of-state stays in partial hospitalization programs. One stay was covered by insurance and one was not. Again, the struggle is finding a provider that's willing to negotiate an agreement to pay for the services. Not only do you have the cost of the services, but for a partial hospitalization program, requires that the individual, your loved one, that they continue with the daycare at a facility, but then they come home to you at night. So that requires you to also have either an apartment or an extended stay somewhere so that you can be there at night to provide the services that are needed. When you get past a partial hospitalization program and the residential program, you step down to the intensive outpatient care. My granddaughter has gone through 2. One was covered by insurance in state. The other was not. Recovery takes a long time, lots of work, lots of money, and a qualified team of professionals. From 2018 to 2020, we have paid over $160,000 for inpatient and outpatient services, including residential stays, partial hospitalization care, and outpatient care that was not covered by insurance. My granddaughter continues to receive individual therapy with an eating disorder specialist and nutritional care with a registered dietitian at an annual cost of about $25,000, all of which is not covered by insurance. If you have a loved one, or if you yourself are struggling with an eating disorder, your options for care in Kentucky are very limited, with having only one outpatient therapy program in the Louisville area. Any level of care required above that has to be received out of state. So not only do you have the cost of the treatment if the provider is unwilling to negotiate a single case agreement, but you also have travel cost and living cost. In your packet of information, I believe you have an article from the Wall Street Journal, and the title of that article is called "Why It's So Hard to Find a Therapist Who Takes Insurance." This article sheds some light on the obstacles facing Kentuckians and seriously all across the country for those that are trying to seek treatment for eating disorders. The article states the reason for that, or that the fees being paid are about 1/3 to 1/2 what you can charge out of pocket. Also, the paperwork and the restrictions of care that are covered. Again, I truly appreciate the opportunity to be heard this afternoon. I appreciate the work that Senator Rocky Adams has done on this issue, and I appreciate the opportunity to continue to have these discussions.
Great. Thank you all for your testimony, and I too want to thank Senator Adams for her help in establishing this council. Clearly, the state of care for eating disorders in Kentucky needs attention, and that is what we are here to do. Based upon this testimony, it is evident that Kentucky must change some of its mental health insurance laws. First and foremost, we need to improve reimbursement rates for existing providers so that the providers that we already have in our state can provide care to those that so desperately need it. We also need to create some incentives for practitioners to want to practice in Kentucky. Improving the reimbursement rates will help. Tax incentives, educational opportunities, we need to attract qualified individuals to Kentucky. We also need to change the review criteria for eating disorder care. It needs to accurately reflect what care for an eating disorder requires, and we need to ease some of the state licensure laws for cross-state telehealth services so those in areas that are unable to access care have that access. And I know we've probably gone over our time, so there's a lot more information we have in the presentation. But in summary, what we are asking as a council, we want to fulfill the job that we were formed to do, which was ultimately provide more access to quality care for Kentuckians. So we are asking legislators, this committee, the Department of Insurance to really take a very serious look at, first off, the reimbursement rates to see if we can move the ball forward and actually get the care that the residents of our state deserve for this disorder. And we thank you so much for your time, and we're open for any questions you may have.
Thank you all. Thank you for being here this morning, and thank you for the presentation to the members. We do have some committee members who would like to be recognized. First is Senator Gerdler.
Ms. Labarsky?
Yes.
I have a daughter who's a psychologist today because of an eating disorder when she was 13-year-old. And the reason the eating disorder come along is because even as beautiful as she was told she was fat. And so we didn't realize what was going on and anyway, as we learned more about this, my wife knows all about it. I know a little, enough to be dangerous probably, but it's more of a mental aspect, and then it turns into a physical aspect.
Absolutely.
And, you make yourself physically sick after you're mentally sick. Now, she didn't go on to the point of needing hospitalization and all that stuff, and thank God she didn't. The question I have, and there's two of them, since Instagram, doctor, do you see more of this because of little girls getting on there and beating on other little girls? I know us boys, we didn't care. But it always seems like, and I'm sure you probably got some gentleman, some young man, but it's always in the young ladies. They all want to look like Senator Rocky Adams, but they have to look like Senator Gerdler. So anyway, the point is, I guess my basic question is it more prevalent today because of media or because of the things we have?
Yes, I think that has been documented in the literature as well, that those outside pressures are there and really kind of unavoidable to the growing adolescent brain, unfortunately. So they used to show old studies saying that just fashion magazines would affect your self-esteem, but now it's so much worse.
Or Barbie. Mm-hmm. Yeah, I'm so sick of hearing about how Barbie's caused our problems. Barbie ain't caused our problems. Yeah. Problems is and I know it turns into a physical aspect of it. That was my biggest thing. What are you having problems collecting because it's a mental aspect? I know Dr. Alvarado, where you at, Doc? Right behind you. You'll stab me again, ain't you? No. All right. Anyway, Dr. Alvarado deals with a lot of the physical part of it, and the physical part of it is probably covered the things it brings on with the stomach ailments or the things that goes with the anorexic or all that. I don't know if is that a problem getting paid, trying to draw the line of what's physical and what's mental, or
I think it's the problem with eating disorders is it's very complex. It's a little bit of both. You need to take care of the medical side of it, and until the medical side is kind of brought to where the patient needs to be, where they are healthy, then the work begins on the actual changing of the thought patterns and the psychological side of it. And they kind of, go hand in hand. Just because someone is weight restored with an eating disorder doesn't mean they're cured. That's actually when the true work begins, because they have to learn how to maintain it and recover it. So it's so long term, and I think a lot of the insurance companies base their decisions on calculable medical criteria, but it's not just solely a medical situation. It's very different than a substance use disorder or even, anxiety or depression. It's very complex.
One more thought. We treat alcoholism, and that's brought on by mental aspect too. So why can't this be and I'm an insurance person, or was, I retired, thank goodness. But I don't see these young ladies, and they do have a major issue. When it come to be with me is when the carpenter lady that had the most beautiful voice I ever heard in my life, Karen Carpenter, was a skinny, beautiful-looking girl. And I never did understand that until my daughter went through that and realized then that no matter what you see in the mirror, you see something else, and it's ridiculous. And, of course, you ladies, I hope this, if it offends you, my opinion, I guess, you ladies are hard on each other when you're 13 and 14-year-old. And it just, it brings on an aspect that you live with for the rest of your life. And my daughters still, both of them are psychologists, but they still have issues, But anyway, thank you.
And if I may, I think the disorder seems to be more prevalent in females and in young girls. I don't want to forget that there are young males and males who suffer from this disorder as well. In fact, the first residential program where my granddaughter was, there were two young gentlemen there. So it doesn't discriminate. Thank you.
Thank you. We have about 4 more members who want to get in questions on this topic, and we'd like to wrap it up in about 10 minutes and then move on to our final topic for the day. So, Representative Westrom.
I wanted to thank you for coming here today, because within the last 4 or 6 years, we've had so many new members, and their education comes in our committee rooms from people like you. And this is such a broad-based topic, eating disorders. I remember when I started in the General Assembly, we weren't providing enough funding for metabolic food disorders for babies who were born with issues because they couldn't eat real food. And it took about 6 years to expand the diagnoses that would be funded by the state of Kentucky. And so certainly coming before us and educating is absolutely a very appropriate thing to do. And I hope that our members understand that this is difficult. This is a difficult topic, especially for parents who have lived with it and seen the aftermath and the dim hope for the future on really bad days. Can you give me the number again in the state of Kentucky that are diagnosed with eating disorders?
Yes. Currently in the state of Kentucky, there are 900,000 individuals diagnosed with an eating disorder, and of those, a little over 29,000 are children or adolescents.
Wow. Thank you very much.
Senator Alvarado.
Thank you, Mr. Chairman, and thank you all. A couple of things, I think, on just some of the comments you've made. I'm a pediatrician also, and I've had patients present to me with eating disorders, parents concerned, people that need to be hospitalized. And I think sometimes it's important for us to talk about the graphic nature of what this disorder is. We think about it. I think people often think, well, it's just, you need to eat. If you just eat, you'll get better, you'll be fine. And that's as simple as it gets. And for most of us, that's the mentality if we don't have the disorder itself. But these are individuals who, if they have any aspects of bulimia, as they throw up, the acid, the corrosion of teeth, the damage to their esophagus, obviously the weight loss, the electrolyte abnormalities that occur, end organ damage that can occur from those things. People's potassiums get very, very low. All kinds of electrolytes can be really messed up. And so often for me as a pediatrician, you'd admit them, you get them hydrated, you correct all those deficiencies, and you were left a little bit with, what do I do now? And not being a psychiatrist or an expert in this field, you talk about having to attract more providers into the state that are willing to do this. And so we've had a severe mental illness task force that's been working on this topic. I think the very first meeting we had was it was really a shortage of providers. And I want to remind all of our members that there was a task force that was set up to address the shortage of providers, done in 2013, with several recommendations that are there that we've proposed those recommendations. And I file some of those every year. I'll continue to file those every year. And in hopes that some of my colleagues will start to take this matter seriously, because the longer we wait, the harder it is to attract providers. We can't pop them out of a gumball machine. It takes for a physician 11, 12, 14, 15 years to get a physician in that role. And if we start the process now, we'll be seeing those effects in 10 or 15 years down the line. I can go on for a long time. I won't bore everybody to death. So I appreciate some of the comments you've made about the importance of that. Can you describe some of the specialists you need? Obviously, can a board-certified pediatrician be the aspect? We know that child psychiatrists are often sometimes what we need, and we've only got 59 child psychiatrists in the state of Kentucky. Only half of those take any kind of insurance. The rest are self-pay because they're up to here with dealing with insurance companies. And they're full. They're absolutely full with people paying self-pay. Not everyone can afford that. Maybe you can talk about the specialists that are required in all aspects and what we need to help attract those.
Right. So ideally, and thankfully, I do have a team that works with me at Norton Children's, but the child psychiatrists are key, child and adolescent psychologists as well, registered dietitians that actually have training in eating disorders. Not just any registered dietitian will have knowledge of how to counsel through this illness. It really is multidisciplinary. We have other types of therapists like expressive and art therapy, child life therapy is what I have access to with my team. But it takes more than one person, that's for sure.
Also, with regards to telehealth, Mr. Chairman, if I could briefly, we probably have, I would argue, the top telehealth bill in the country right now. And as long as a provider is licensed in the state of Kentucky, they can see patients from anywhere in the world. Not all states have that. Many of them say you've got to be within our state borders. As long as they're licensed in the state and they're willing to get a Kentucky license in whatever field, they can provide those services from anywhere. And we've worked very hard, and Representative Frazier and myself have run those bills in the past, that many states are starting to try to copy what we're doing here. So know that the telehealth laws are pretty expansive. If you've got providers in other states who want to see our patients here, as long as they're licensed, they can provide that care from anywhere. So we try to expand our borders as much as we can to let people be treated by the specialists that we need. But tort reform is a big thing. I'll be filing that again. I know members of this committee, most of them are in agreement on that topic. We've got to start looking at that as well as a big issue in the state. And again, some of those recommendations, I would urge everybody to remember to look at that in the future. Thank you, Mr. Chairman.
Senator Rocky Adams.
Thank you, Mr. Chairman, and thank you all for being here today. And it really is an honor to work with you all on this. And I agree with Representative Westrom. We have 900,000 people in this state who are affected by this disorder and disease. I was hoping, Mr. Chairman, if it was possible, if we could have Sharon Clark comment on this testimony today. And
Sure, that's fine.
$1.5 million and $900,000 with an eating disorder.
Commissioner, are you still with us?
I am, sir. I am going to defer to Mr. Orm, who is a health insurance specialist.
Good morning, Mr. Chairman. Well, I mean, certainly that's something we're going to look at under the Mental Health Parity Act that's been passed, House Bill 50, and see how that's going to presently affect going forward, how to enforce that parity among the different providers of the medical and surgical and the mental health aspect of it. There's not specific language now mandating the coverage, but we're going to look at how the bill going forward would operate in operating parity.
And I would add that, the department is certainly willing to facilitate a communication session with the health insurers and members of the council to try to update them and, to explain the issues that they're having. And I think it was Dr. Krause that was saying that there was, they were unaware of some of the, the provisions of what is needed. But, we would certainly be willing to do that. I will tell you that the department traditionally does not see it as a role, nor does any department of insurance in the country, to get involved in reimbursement rates. We consider that a private contract between the provider and the company.
thank you for that response. And I look forward to, it's not just a parity issue, but it's an equity issue. And it's an issue that if other states have figured out how to achieve parity and how to achieve equity, then I'm sure that Kentucky can figure out how to do the same thing. So I do look forward to this council interacting with the Department of Insurance. I think it's important that we have those conversations. And I know I stand ready, along with, seems like many members of this committee, to continue trying to help in that effort to get that parity, to get those reimbursement rates, because quite honestly, our citizens deserve it. So thank you very much for all the work that you do.
Thank you. Our final question on this topic this morning will come from Representative Roberts.
Thank you. Thank you to the presenters. One quick thing. I had the great honor several years ago to teach for an extended period of time mindfulness and meditation to the Eating Recovery Center in Cincinnati, and had some firsthand experience through this and the great work that you all do. That facility is the closest one to people in my district, but it is out of state and out of network for many, and so I've also heard some of those same issues. I'd also like to just take this opportunity to remind us all that words really matter, and that when we're here and we have the microphone, I just ask all of us to be as thoughtful and compassionate as possible. When I was there, I noticed that it was maybe predominantly female, but not entirely by any stretch of the imagination. And this isn't a problem of girls being mean to girls. This is an issue that society needs to face. And it's generally people who feel a lack of control in their lives, and this is one way to have control. So I just ask us all to be gentle with our words. My question is this. Given the problems we face and the solutions that you presented to us, some of which may take us some time to solve, could you talk about any ideas you have for early intervention, ideas that might be able to help us in the shorter term, and specifically where it comes to really trying to get young people to go into the psychiatric fields and the mental health field so we can start to grow a crop of new providers for our state? Thank you.
Well, thank you for your comments. I can address part of your question. I'm not sure I'm qualified to do the second part. Some of the things that the Kentucky Eating Disorder Council has been working on, first of all, is already utilizing the already established community mental health centers and leveraging the care in those communities that already exist by providing educational opportunities for those people there so things are detected earlier, introducing prevention programs. We've already done, I wish Kate Wagner were here, our administrator. We have a list of all the presentations that we have done to stakeholders in the state, letting them know what is possible and the goals that we have as a council. We're in the process of finishing up our strategic planning for the next 3 to 5 years, and we'll be able to lay out a really comprehensive plan as far as some of those things. We're doing an advocacy day in March that we will have lots of information. We'll be in the state capitol rotunda for that day, and every week we're working towards providing more information and using systems already in place through the prevention branch. You have to keep in mind, too, that everyone on this council is doing this as a volunteer because they're passionate and they care about this issue. And I wish I could work full time on it. Unfortunately, I can't. So we're moving forward, and I think we've accomplished a lot. As far as attracting more young people into the mental health fields, I don't know if you have any thoughts on that.
I think that I'm associated with the residency program, the pediatric residency program through University of Louisville. And so definitely our outreach there is for ongoing education. And as well, the psych team that I work with also have interns and postdoc fellows that come through their program as well. It's just, I do feel like a lot of those people end up not staying and kind of going away to different states. So, thank you.
Thank you. And thank you all for being here this morning and for the time you put into your presentation and testimony. I think it was a really good educational experience for our committee members, and those are the kind of topics that we like to hear about in the interim. So thank you all for being here.
Thank you so much for your time.
All right, our final topic this morning will be regulation of air ambulance membership restrictions. I think going to the table first will be Representative Deanna Frazier and Chris Brady with the Senior Vice President and General Counsel of Air Methods. Representative Frazier, when you're ready, introduce yourself and your guests for the record, and you may proceed.
Good morning. I'm Deanna Frazier, representative for District 81 in Madison County.
Good morning. My name is Chris Brady. I'm the General Counsel at Air Methods Corporation.
Chairman Rowland and fellow members of the Banking and Insurance Committee, thank you for taking the time today to hear about an important issue that deserves our attention. Because as lawmakers, we're responsible for making sound public policy to protect our constituents. Air ambulance membership policies are sold all across our Commonwealth. They're sold at state fairs, at shopping malls, at kids' ball games, and also by mailers. But what they are and what benefit do they provide to policyholders? On its face, an air ambulance membership subscription claims to protect against out-of-pocket costs in the rare event of transportation by an air ambulance. But who, if anyone, actually benefits from a membership policy in the event of transportation? Do your constituents know that the vast majority of them are already covered by their traditional insurance in the event that they need an air ambulance? Medicare and Medicaid have very little out-of-pocket costs for such services, and private insurance is now going to in-network with many of the air ambulance companies. These memberships are products that transfer an unknown amount of risk from the policyholder to the air ambulance company in exchange for a premium payment. Why aren't these policies regulated as insurance? The discussion today is not about banning these membership products. It's quite the opposite. What I propose to provide your constituents and my constituents is the consumer protections and rate transparencies that's provided to them on every other insurance product out there in the marketplace. Further, when the Federal No Surprise Act goes into effect on January 1st, thereby preventing patients from receiving balancing bills, what benefit will these policies then provide? And that is the question I want to answer for my constituents, especially those on fixed incomes who are buying these memberships out of fear. It's time that we take a hard look at these policies and provide consumers of Kentucky with needed protections from predatory policies and marketing tactics. For example, in Kentucky alone, Currently, GMR says that there are 287,000 memberships at an annual membership cost of $85. If you do the math, that's $24.4 million. 0.1% will actually utilize this service. Would we let United Healthcare, Blue Cross, Aetna, or any other insurance providers operate with that kind of loss ratio? I'd now like to turn it over to Chris. Thank you.
Thank you. Chairman Rowland, Chairman Carpenter, members of the committee, as I stated, my name is Chris Brady. I'm the General Counsel at Air Methods Corporation. Air Methods Corporation operates 7 air medical transport bases in the state of Kentucky. You know, we have over 100 employees working on the front lines of healthcare to deliver these life-saving services to your constituents. I'm glad to be here today to discuss a very important topic for consumers in Kentucky and the regulation of air ambulance memberships. I understand there was legislation introduced last year on this issue. However, this is the committee's first hearing, and I'd like to provide some updates given the evolution of the implementation of the No Surprises Act and continued regulation of these products in other states. To be clear at the outset, I am not here today to argue for the prohibition of air ambulance memberships, as unfortunately you may have been told. Rather, Air Methods supports state regulation of these products by the Department of Insurance to ensure that consumers are protected in the same manner as policyholders of other forms of supplemental insurance products in Kentucky and not deceived into purchasing coverage they simply do not need. The pending enactment of the Federal No Surprises Act makes this issue even more important than ever before. Air Methods continues to believe that the best way to solve for the patient financial burden is to go into network with payers. We have led the industry in doing just that and have in-network agreements with almost every major payer in every state and continue to work hard to get the final 3, Aetna, Cigna, and United, into network. As a reminder, the No Surprises Act was voted into law and will become effective on January 1st, 2022. This law significantly changes the landscape of the U.S. healthcare system and virtually eliminates financial risk as it prohibits the practice of balance billing. Consumers with any form of healthcare insurance will be responsible only for copays and deductibles. This shift obliterates the fundamental basis for memberships, which have been and continue to be marketed to cover patients' financial exposure to balance bills, which again will be prohibited in 52 days. Despite the looming change, consumers continue to be sold multi-year products to protect them from a problem which will no longer exist, without any actuarial adjustment to premium pricing by the companies selling these products. A simple reduction in premium pricing would ensure that policyholders are being charged a fair premium reflective of the lower dollar amounts being covered, which will now only cover copayments and deductibles. Yet this shift has not occurred because these membership products are unregulated and operate without any oversight. State regulatory oversight is necessary to ensure that consumers are not being charged premiums that reflect the risk of balance bills, premiums that would now be inflated and incorrect from a pooled risk perspective, and should result in a substantial savings for policyholders. Facing this looming shift in the air ambulance industry, purveyors of air ambulance memberships have shifted from describing memberships as prepaid air medical services to a prepayment of deductibles or copays. This narrative shift glosses over 2 significant flaws in these products that continue to lead to consumer harm. First, many consumers are sold memberships without appropriate disclosure and with fear-driven pressure tactics. Even more concerning, these memberships may auto-renew, leaving consumers locked into yearly premiums even when they reach Medicare coverage age. Profiting off consumer fears of facing a lifetime of economic insolvency if one were to need air ambulance transportation is both ethically wrong and highly questionable. This is even worse now that the risk of balance billing has been eliminated. The predatory nature of air ambulance membership marketing is highlighted by the fact that air medical memberships continue to be sold to millions of Medicare beneficiaries each year, despite these policyholders only having limited coinsurance costs. We already know that in some states, 35% or more of consumers who purchase these products are Medicare beneficiaries. When comparing publicly available data with data from the NAIC and AHIP on the U.S. Medigap market, the largest membership product in the United States, Air Medcare network, is technically the second largest Medigap product sold, second only to United Healthcare, but without any regulatory oversight. To further illustrate the dubious benefit of these products, roughly 70% of Air Method's Medicare beneficiary patients paid less than $50 out of pocket in 2019 because the majority of these patients already had other supplemental Medicare coverage. Rural Medicare beneficiaries are particularly vulnerable to the sales pitch of air ambulance memberships as they live in remote areas where the majority of air ambulance Medicare transports originate. Yet they have the fewest financial resources available, with over 42% of rural Medigap policyholders relying on annual incomes below $30,000, according to AHIP's 2019 analysis. Rural seniors should not be made to think that they must allocate their hard-earned dollars to buy air ambulance insurance coverage that is, in most cases, duplicative of their existing Medicare or Medigap coverage. Nowhere on any air ambulance membership websites are consumers alerted to the potential for duplicative coverage between their existing Medigap coverage plans and air ambulance memberships. Instead, Medicare consumers are offered a discount to encourage membership and provided conclusory assurances that air ambulance memberships could be useful if supplemental insurances did not cover copays or deductibles. Only Medicaid consumers, for whom there is absolutely no benefit, are specifically mentioned, and there the burden is passed to the consumer rather than the seller to understand that they are prohibited from buying a membership. A paper prohibition without any enforcement or oversight is the definition of form over function and allows membership sellers to bury their head in the sand while profiting off our most vulnerable consumers. Positioning these products as covering copays and deductibles also ignores the fundamental realities of emergency air medical services. As a starting point, as was mentioned earlier, our services are exceedingly rare. Consumers have approximately 0.1% probability of being transported in any given year. Further, air ambulance providers may only be dispatched by either a first responder or a physician. This process ensures our services are medically necessary, but also highlights that air ambulance services often fall on a continuum of care that is bookended by services from other medical providers. For example, a patient who is treated by first responders after a car accident, flown by air ambulance to an emergency room, and discharged a week later will have insurance claims related to at least 3 different service providers. Given the acuity of our patients, these insurance claims are often expensive, and a single claim may fulfill the patient's maximum out-of-pocket responsibility under their insurance policy. The benefit of a membership in these situations simply comes down to which healthcare provider submits their bills first. Selling a membership for a service that a consumer has less than 0.1% of activating, no less needing, under the guise of providing peace of mind, is dubious at best. Membership products are marketed and sold as insurance products. Consumers identify them as such and treat them like other health insurance products, even delaying care to ensure they are transported by a covered provider. Air Method's own records indicate that over 200 patients have delayed care to wait for a covered air ambulance membership rather than utilizing the closest, most appropriate provider selected by a third-party first responder or physician. Further, just this year, a Medicare patient in another state refused transport with Air Methods to wait for another provider due to a membership. The membership provider was not available for several hours, but the patient still refused a non-covered transport and eventually passed away in the hospital. This is a preventable tragedy driven by a phantom fear of balanced billing that powers the sales of memberships. Air Methods has long supported policies that take the patient out of the middle of the emergency healthcare billing process. We have effectively eliminated balanced billing for our patients in Kentucky through the implementation of our patient advocacy program and by going in network and building strong relationships with our great partners like Anthem, Blue Cross Blue Shield, and Humana. The passage of the No Surprises Act only reinforces the need for oversight of air ambulance memberships to protect policyholders from predatory products designed to solicit premiums while effectively providing no value to them or their families in return. Companies that sell memberships believe these products operate above state law. However, states can and do regulate air ambulance membership subscriptions. Good examples of this are Florida and New York, and the National Council of Insurance Legislators continues to study model legislation that would serve as a blueprint for states wanting to rein in predatory behavior. I would encourage this committee to remain steadfast in protecting Kentucky consumers and ensuring appropriate regulation of air ambulance memberships.
Thank you. I think what we'll do is allow Global Medical Response to come to the table for their response, and then we'll do questions. We'll do questions after that. So we'll get them all at the same time. Elizabeth Ward, Regional Director of Kentucky Operations for Global Medical Response, and Jason Mundy. Please introduce yourself for the record, and you all may proceed.
Hello, I'm Elizabeth Ward. I'm a 1993 graduate of Eastern Kentucky University. I'm a resident of Kentucky. I'm a Kentucky licensed registered nurse and emergency medical technician. I'm here today representing Area Back Life Team. I have worked for Area Back Life Team for more than 20 years, and I'd like to publicly thank many of the members of our audience today are here also from Area Back Life Team. More than a dozen people in the audience today are with my organization. I have the honor to sit here and represent them. In Kentucky, we have 17 bases of operation physically located in the state. If you look at the contiguous states, we have a total of 33 licensed aircraft to respond in Kentucky. We serve whenever we're dispatched, without regard to membership status or the ability to pay. Over the years, I've heard from many members that have stopped by the base or seen me in the grocery store, and they take pride in their membership. They take pride in being a small piece of an organization that makes a difference in their community. They'll often say, I hope I never need you, but I'm glad you're here. Our programs help give them a peace of mind in their community. And as a nurse, that is important to me. Membership does matter. And I don't want to take up too much time, but because membership matters, I did invite, we have here with us today, our subject matter expert. I'd like to introduce to you our National Director of Membership Field Sales, Mr. Jason Mundy.
Good afternoon, and thank you for the opportunity to testify today. As Elizabeth said, my name is Jason Mundy. I'm the National Director of Membership Field Sales for the Air Medicare Network, which is a global medical response solution. I am here to testify against proposed changes to 21 RSBR 1296, classifying air ambulance providers that offer membership to be considered as insurers, and also air ambulance provider membership programs to be considered as limited health service benefit plans. Global Medical Response has numerous air ambulance bases providing life-saving services within the state. We have provided air ambulance memberships in Kentucky for over 21 years. Currently, more than over 200,000 Kentuckians, most of whom live in rural communities nearby our bases, have made a consumer choice to be a part of the Air Medicare Network membership program. They do not want you to take away their choice to have a membership. I have confirmed we, GMR, are now a network with over 92% of the air transports we provide in the state of Kentucky. We are pleased to be contracted with both the largest commercial insurance companies in Kentucky, Anthem Blue Cross Blue Shield and United Healthcare, providing in-network coverage to 83% of the commercially insured members in Kentucky. I doubt our competitors, like Air Methods, have in-network numbers nearly as good as ours. If they are here, we would encourage you to ask them. Our Air Ambulance membership is a prepaid plan that covers any deductibles, co-pays, and co-insurance requirements if a member is transported by a GMR company. We clearly understand the facts as outlined by the Kaiser Family Foundation, which indicates average cost sharing for a family has increased by 70% with both employer and employee spending increasing faster than workers' wages. Therefore, we don't take a dismissive approach to what matters financially to our patients. Instead, we offer the consumer a choice. $5,000 and $10,000 deductibles are real money for real people. Our members have the financial peace of mind of knowing that if one of our ambulance teams transport them, which are requested based on state protocols, they'll have no out-of-pocket costs for that transport. As clearly defined in our standard terms and conditions, which members acknowledge during the enrollment process, we don't cover transports by a different air ambulance company. I invite you to visit our website, airmedcarenetwork.com, to see this for yourself. Our patients who are not members and that may have claims paid at lower out-of-network levels are supported throughout the process by our patient advocates who work tirelessly, doing everything within their power to work with the patient's insurance company in an effort to lower the patient's financial exposure. Finally, air ambulance memberships do not constitute the business of insurance under the McCarran-Ferguson Act. Global Medical Response has won a lawsuit against North Dakota and 2 back-to-back lawsuits against West Virginia, substantiating states cannot regulate air ambulance memberships as insurance. West Virginia's attempts failed under both its pre-existing insurance statutes and under new statutes that Air Methods, a GMR competitor, helped them specifically craft in an attempt to skirt ADA preemption. Membership plans serve a vital role for rural communities, and they are consumer friendly. For example, we saw Wyoming reverse course after it had attempted to overreach an air ambulance membership regulation. They tried to treat it as membership and changed it a year later. For these reasons, we respectfully request that the committee not advance this bill. Thank you.
Thank you all. Thank you for being here and your testimony this morning. I guess we probably, Chris, if you don't mind, come back to the table, and we do have some members who would like to be recognized for questions. First is Representative Frazier.
Thank you, Chairman. I noticed that Commissioner Clark, is she still available online?
Yes, sir. We're here.
Great.
Yes, ma'am. We're here.
Okay. Well, thank you. I would just like to get your opinion regarding this issue, if you would mind to share that with the committee.
Yes, Representative Frazier. The Department of Insurance did support the legislation that you introduced last year on this. I believe it was the in-call model. There was one deviation that we had from the model, and that was on the response time on complaints. You know, the department feels a responsibility to protect consumers and to educate consumers. And really on this issue, I don't know if there is a complaint on one of these memberships. Who do they go to? You know, what administrative body? To the point, are these fully insurance companies? Do they have to have a certificate of authority in the Commonwealth? We would certainly have to look at it closer, but I would think as Global has described it, perhaps that's not the case. However, there is a process of registering with the department, which is not a full line certificate of authority. It's a registration similar to pharmacy benefit managers or utilization review entities. And that would give the department the ability, should there be a complaint on this membership, that we could administratively review it.
Follow up. So to summarize, would it be correct to say that you believe these memberships are insurance products and the states have the right to regulate them?
Yes.
Okay, thank you.
Thank you. Representative Kirk McCormick has a question.
Thank you, Mr. Chairman. Can you hear me?
Yes, we can. I think you accidentally muted yourself.
I hope she's not driving.
Can you hear me?
Yes, we can now.
Thank you. I think it's my signal that comes and goes. I've had an opportunity to research this issue a little bit, and I just kind of want to I have a question. It is my conjecture from my research that state law cannot regulate these memberships. Whoever can answer the question. Is that correct?
That is correct.
Representative McCormick, we would respectfully disagree. I think there has been litigation on this in various states. You know, there's very, very strong arguments on either side. However, our belief is that the McCarran-Ferguson Act was put in place to allow state legislatures to regulate the business of insurance. This is not a question of the Airline Deregulation Act or the ADA. It simply comes down to a question of whether or not these products are insurance products. There will be testimony at the NCOIL meeting next week from an outside law expert that we are bringing in that will provide a brief that would suggest that these are insurance products and they are able to be regulated on the state level.
Okay. I was under the assumption that it could only be done on a federal level. Have a second part to this question. We live in a rural area, and to get good quality health care in a major medical event, we have to rely on AirVac. This is a service that we very much want to keep. Personally, I have a $2,500 to $3,000 out-of-pocket deductible, and I really don't have that membership at this time. But after researching and looking at things, you know, I'm inclined to pick up that because it's household, not per person. $85 versus $2,500 to $3,000 out of pocket per event is a very good savings. So I can see some pros and cons to this request for this bill. I'm going to be looking at it much closer. My son is in paramedic school. He works weekends as an EMT, and you know, we talk. We have a regular relationship, communication about his job, and his goal is to be a flight paramedic. So, you know, I know that I've watched over the period of the last 10 to 15 years, and it seems like they're very busy. There's more medevacs out of our little county per week now than what there's ever been. So I even brought up the question, are they overusing, you know, AirVac? And, you know, that's the ground call. So, you know, I was told that there's no incentive for the ground people to call in a medevac unless they feel that it's very essential. So when you got a life hanging in the balance, you know, $85 a year membership is not, you know, going to sway anybody. You know, so I want to be fair, I want to be open, and I want to take a very close look at this issue. So I would encourage all the other members to do so. Apologize for that noise. I'm having to use McDonald's Wi-Fi in the parking lot. So just, I'm going to be looking at it closely, and I just encourage everybody else. I respect Representative Frazier. I trust her judgment. She's always been sound and rational. Let's just take a close look at this because we don't want to do something that's going to cost our seniors and us retirees a lot of money out of our.
She did her homework.
Afraid she's lost her signal. Thank you, Representative. A moment ago, somebody referenced NCOIL and the meeting that some of us will be attending next week. Over the past week or so, there was a letter that went out, and it might have gone out to all 287,000 members of Kentucky, but it referenced the NCOIL letter and asked them to reach out to us. And I'll paraphrase, I don't have a copy of it, but it basically said that if NCOIL were to pass that bill, or if we were to pass a bill in Kentucky, memberships would no longer be available. They would be outlawed in a sense. Can you address that? Can you point out where you believe that either in the NCOIL language or in the Kentucky model that upon passage memberships will no longer be available?
I can address it, yes, sir. Can you hear me? Mm-hmm. Specifically, our product is not an insurance product. So, regulating us or creating a bill that says it is an insurance product, you obviously have a differ of opinion there that we're not an insurance product. We're also not an insurer. So anything that changes or affects us to become an insurance product or insurer could jeopardize our ability to offer membership to Kentucky residents. So obviously we'd have to go back and take a look at the business model and how we go through the business model and the costs incurred with those changes. So yes, we are aware of that letter. We did notify our members because it is their consumer choice. They're buying these things because they see value in them. The representative earlier made some very critical points. The $2,500 to some is real money. That's a significant impact to them. She also referenced the household plan, and that's very important with the membership product. It is a true household plan. So it's not just covering one person, because in the household you could have a very divided mix. You could have somebody who's on Medicare, somebody who's on Medicaid, somebody who's commercially insured, and somebody who's uninsured. So the Pew Research Group right now shows there's 70 million non-traditional household members across the nation. This is where a very big value of our membership product comes into play, because we're covering any and all people that live underneath that residential roof for $85 or less a year.
Thank you. And I'll follow up a question, and we have some other folks that want to have some questions here. But just so I'm clear, so if this state or any other state passed a bill that said this is an insurance product, you got to report to the department, you got to be transparent, you got to get a certificate of authority to transact, you would probably not want to do business in those states upon passage.
We'd have to reevaluate that. We'd have to evaluate the impact on the business and what type of changes it would cause the product itself. As far as consumer protections, we've always been about consumer protection. If that's the goal of the bill, we fully support that. We have it in COIL in multiple other states. Our terms and conditions, and for example, if you look at Wyoming, they actually took our advice significantly and used our product as a model to distribute that type of consumer protection. So we address things such as Medicaid. As referenced earlier, asking somebody to validate and confirm whether they are on Medicaid or not, so we can advise them that they don't have a need to purchase a membership if they're on Medicaid. If it's going down the path of where it's going to be defined as an insurance product, we disagree that it is not an insurance product and we are not an insurer. So can't give you a definitive of what path it'd go. We would have to evaluate that, and it could have significant changes on the residents of Kentucky's ability to purchase it.
Okay, thank you.
Yes, sir.
We'll move on to Senator Gerdler.
Thank you, Chairman. First of all, I'd like to make a comment. I'll try this time not to offend a legislator as a life experience of parents of 2 girls and a boy. So if I offended anyone else, I'm sorry, but that's my life experience as a parent of 2 girls and a boy. All right. Second of all, I've always heard FAA. And being a licensed pilot and having to deal with FAA rules and FAA laws and all the things, does this insurance have anything to do with FAA? Will it deteriorate in any way?
Senator, from our perspective, there is no issue with the Airline Deregulation Act. At this point, one of the only avenues for consumers to raise concerns is through the FAA, through a hotline number that I believe is available. The efficacy of complaining to the FAA on an individual basis, I don't have personal experience with that, but I think we've all seen the FAA, quite candidly, has a lot on their plate and may not have the resources available to dedicate to individual consumers.
We would disagree. Obviously, the Airline Deregulation Act actually has the preemption built in there that it is controlled at the federal level. There are opportunities for consumers to file complaints at the state attorney general level. If there are any complaints, we're eager to know about them. We take great pride in our customer interaction and how we treat and engage with our customers. That's why the majority of our members are exceedingly retaining to us at 87% or higher year over year. They see value in the product. They enjoy the experience with us, and we do our best to be as transparent as possible and make sure they understand if membership can provide a value to them, that this is what that value could be. Again, we're unaware of any complaints at the state level, and we would be happy to hear those if they are, so we could address those individually.
With the, and this is probably for Representative Frazier or even the Department of Insurance, in selling a product, and me being in the insurance business for so long, you have to have actuaries to figure what this product would sell for? And are there other states that have this product that has actuaries to know what price to sell? And then would it be a rider that you can exclude or include in a health policy? Would it, like if it's a group policy and you say, yes, I want to add air meds on, and then also another thing I have, and we're talking about memberships. Probably the biggest company we got, and one of our biggest help in the whole insurance industry is was one of my competitors, Farm Bureau. Well, you got to have a membership with them before you can buy their product. Is this a hindrance to some of that? And I understand my mother had to be, by your company, taken to Lexington from Somerset, and she was a Medicare patient. So I guess my biggest question is, how do you make it? And I'd be tickled to have it as a product, but how do you figure as actuary, and is all that things go into it, and how long would it take to develop this product?
Senator, thank you for that question. On the knowledge of if a state has any thing instituted to control pricing on membership, we're unaware of any of that. We don't know of any single case of that. As far as the rest, I'm not sure I quite understand if you're talking about the actuarial side of it. That is, one of the concerns, because with membership, we control own operator lease our aircraft. These are our aircraft. This is our company. So what we're doing to our consumers is we're offering a prepaid debt relief option. So they're buying it in advance in the event that they utilize those services. No matter what happens, as long as it's one of our participating aircraft, we're going to eliminate any debt that their insurance may not cover. This is any and all insurances, as referenced earlier, where somebody referenced, an auto insurance, homeowner's insurance, and medical, things of those natures. This is what membership does. In today's time, the feedback we get from our consumers is very, very specific. Understanding insurance is extremely complex, as we heard from the previous testimony. It's very, very difficult for them to understand what their actual financial obligation is. Membership serves as a stability piece. No matter what, if they utilize a service, no matter if their insurance changes, if they go from commercial to private to federal to uninsured, which is a significant population, they are going to owe nothing on the back end to us. So we're going to write all that off. Does that answer your question, Senator?
Yeah, one of the things in experience is car wrecks. That's where you get a lot of this, and that's where you get the reason that somebody's knocked out on the pavement. You don't have a clue whether they've got air methods or air vac or whatever. That's one of the big problems. But yeah, if it's going to be sold as a product, is there somewhere out there that this product that Kentucky can look at to see how it would be priced and what it would cost us on the what it would cost the consumer? And I know that our health insurance companies has in network with a lot of them, and so therefore they're paid. Mm-hmm. What do we do about these that are not?
So, Senator, if I may, I think a couple of important concepts here. Again, on January 1st, regardless of whether an air medical provider is in or out of network, a consumer will only be responsible for the in-network copays of its peers. So the federal government, through the No Surprises Act, has effectively eliminated one of these risks that you speak of. So after January 1st, we're really only concerned with copays, coinsurance, and deductible payments for those individuals that have any form of healthcare insurance. I think another thing that's very important to touch on is that Air Methods, like GMR, I think we both are totally aligned on this. We are very concerned about the financial impact that our services may have on consumers. I think how we've addressed that, however, is very different. Air Methods offers a patient advocacy program that works with patients to understand, their financial ability to pay, if any. We have a robust charity care program that routinely examines patients' financial conditions to see if they're able to pay. And if they're not, then that balance is written off under that charity care program. I know that our average out-of-pocket across all patients, insured, uninsured, whatever it may be, is less than $200 for a transport. My understanding, and I would represent to this committee, and I'm sure I'll be corrected if I'm wrong, that the GMR has a very similar program, and their average out-of-pocket is less than $260. So I think when we think about the threat of copays and coinsurance and deductibles, we would agree that a copayment or coinsurance of $5,000 or $7,000 is very, very high. And that's why we've put these programs in place to ensure that we're not putting a financial burden, on consumers as they work through a very difficult time in their lives.
Thank you. Next question or comment comes from Representative Tom Odell Smith.
No, sir, we're private equity.
Have you got a class action against you at this point for practice or some kind of members that are filing against you to try to get regulation on you?
I'm unaware of any cases. I can ask that question with our legal team, though, and respond back to you.
So the only thing that we're in here considering today is take a private company and ask them to be regulated by the government. Is that right? Is that fair to say?
Well, defining us as an insurance product and an insurer representative.
Be defined to go under the regulations of the insurance, right? So to bring more burden upon the company to be answering to the government agency.
I guess that would, your assumption, I understand that, yes, sir.
So I'm trying to separate what we're trying to do here today. And I've heard this discussed for the last several months as I've been in office. There is territories, and my territory consists of your company. I have yet to have anybody complain to me about your service, hospitals, or what's taking place in the area. So I'm trying to figure out why we're addressing.
There you go. Stretch over there. I'll just slide over. I apologize, and I'm trying to get everybody out of here. But I want to be clear on what we're going to be doing, because this is going to be brought up, and we're going to have to make a decision on legislation. I want to make sure I'm clear on the way that I'm looking at it. If there's territories and people are disgruntled with territories, I understand that. But when there's not any disgruntled, and we're asking for a private to be placed under government oversight, that bothers me. Because if we start with, say, your company, where's it going to end at? We're going to start penetrating the private sector and find more and more to bring under regulation of our state and federal governments. And I understand what you're trying to say, that federal's already picked this up. Well, let's see where it goes. If it's going to take care of the issue, then we'd have a non-issue in the legislation coming up in January. But if there is still an understanding here that we have a product in my area that has no issues, and that I get notices that they're happy with the situation, happy with the program of membership or however you designed it, I can't see where we're going to benefit as legislators to bring oversight to a problem that doesn't exist. And I understand the other side is trying to say there is a problem because we're going to protect your people. Well, my people's not asking for it. Now, if you want to go down there and drum them up and get a beat going, then let's talk about it. But don't stir them when there's not any issue in my area. But if you're trying to say I'm looking after them, then find out where they're at that we're having an issue with. And because I haven't heard that in my district. And until I do, I can't see where we need to try to fix something that's not broken in my area. It may be broken in other parts of the state, and Representative Frazier may have an issue in her area, and I'm willing to listen to that. If AirVac or whoever these other providers are really giving her constituents a rough way of going, then we need to address it. I'm for protection, but I'm not for creating another bureaucracy in my area that's not needed. I guess that's what I'm trying to say. We don't have an issue. But if you can show me and bring people that live in my area to say they've been mistreated and there is an issue, I'll be the first to meet with you and say, hey, let's fix it. Because I am here to represent them. But I'm not here to try to create another oversight or government or cost. And to say there's not going to be any cost to oversight is ridiculous. We know that if it goes under a government oversight, there's got to be more people hired to keep the paperwork filled out, and plus they have to charge more to handle that situation. So I'm not trying to pick winners and losers here, because you said you was even not against, you weren't fighting, you weren't against it. Well, then we're on the same page there, but I'm not for bringing on more regulations, is what I'm trying to say, or bring government into a situation when it's not needed. But if you can show me that I've got constituents being mistreated and that they're having a rough time being treated the way they are with this membership deal, because I have not had that. I've had only positive responses to saying that they appreciate being able to have that membership. So again, I want to do what's best, and if you have an issue that's even in the other part of the state where people are really being mistreated, I'm willing to listen to it. But as far as my constituents and my district, if it's only dealing with bringing a regulation, Mr. Chairman, onto a situation of private, then I have a hard time of adding more regulations to private business. And I want to make sure you were private, that you're not a public company. I want to make sure that your membership is a part of the basis for your establishment. And if so, then I just wanted to make sure I understood that part of it. But I appreciate you listening to me. But that's basically all I want to say. I want to make sure I wasn't getting involved in a situation that's not in my area. That we, as far as I know, we don't have anybody crying for help in the membership basis. So again, thank you, Mr. Chairman, for the time.
Representative Meredith.
Thank you, Mr. Chairman. And my question is going to be, when I get to it here in just a minute, is going to be directly for Commissioner Clark. And I'm going to divert in that question from a discussion between basically two competing companies who have very different business models. Frankly, you exist with very different business models. I have quite a bit of background in this issue from personal knowledge, and I think one of the consternation comes, Representative Smith, you mentioned territorial issues, and my rural community that I represent sits kind of right on the line of kind of two different territories there that both of you all have flight bases in. You can get to my community within about 30 minutes drive from your flight bases of either of your companies. And so in my community, you may get a helicopter from either one of those locations at any given time, depending on what the airspace looks like at that point, depending on what the weather is, determining on the availability or any of those things. And there has been some consternation over the years amongst those local emergency responders on the ground of if somebody does have a membership with one company and they end up getting the other company to respond because they're the most appropriate responder based on time or whatever the situation may be, of folks coming back with balanced bills saying, well, I'm a member of this one, why didn't you call them instead of calling the other? Well, those folks on the ground are charged with getting that person to care as quickly as possible and taking care of them. So I understand that consternation. Now, I was also under the belief that most of this was going to be resolved when the Balanced Billing Act and the No Surprise Billing Act went into law as well, because we were moving beyond a lot of this discussion. Now moving into my question, though, and this is where I'm going to divert from the two companies and go directly to Commissioner Clark. I know we have a difficult situation here because it's a determination of, is this something that you can regulate, or is there a federal preemption under the FAA laws because of the membership scenario? I also know there's at least one other company and maybe multiple companies who are operating in state selling what is a membership product, is what they're describing it as, but they are not operating any aircraft, and they work with all of the companies, or that is what they're selling when they sell the product, working with all of the companies to pay and offset the cost that are not covered by insurance. So, Commissioner Clark, what my question is are you all doing anything to regulate the others who are not under the purview of the FAA, but may be serving as a membership type organization, providing a similar service to what this is providing, but involving all of those air ambulance services that are out there?
Well, thank you, Representative Meredith. As you know, for years, and the department has received complaints. I've been a commissioner now. I'm working on my 10th year. We have had complaints throughout the years on the surprise billing primarily. This particular scenario that you mentioned, yes, we are currently reviewing or investigating one of those entities that you described. I can't say any more at that time on that. With regard to the Airline Deregulation Act, that has been an issue for years. And 10 years ago, we would have concerns with the ambulance service, and that act was always cited. However, specifically in the No Surprises Act, that has been eliminated, that barrier. And so we do think that would be an advantage. But again, we are reviewing that practice of that other entity that I mentioned.
Thank you. Representative Stevenson.
Hello. I guess I technically have two questions. Sorry, Chairman, but help me understand from what you have explained. This was primarily, it started out because of balance billing, and now that the No Surprises Act has come through and you're shifting into prepayment for deductibles, co-payments, all that kind of stuff. How has that been communicated to your customers, and have you had any of them to be like, oh, well, are they just saying, oh, this is great, or are any of them saying, oh, okay, so maybe I don't need this anymore? So how are you communicating, and then what's the response been to that?
Is that for me, Representative?
Sure.
Okay, thank you. First, for clarification, it wasn't us who said we marketed it toward balance billing. It was Air Methods that said that, so that's inaccurate. We've always marketed membership toward the out-of-pocket expenses to provide the financial peace of mind that we feel our patients that choose to be members deserve. The complexity behind it is, even though the No Surprise Act comes in place, which is great because we've been a huge supporter of that too, that takes that balance bill, takes the patient out of that process and lets the insurance carrier and the provider go into discussions with that. It still doesn't eliminate not just the co-pays that are referenced, but more importantly, the co-insurances. And if you look at some of these summary benefit guides that are out there, even with an in-network agreement, patients could be responsible for 20, 30, 40, 50% on their co-insurance side of it. What membership does is it's going to relieve them of that obligation to us as a carrier if we have transported them. Does that answer your question?
It does, yes. And if I may, one more. So as you're explaining all of this, for me, and I am not an insurance person, so I will announce that up front. But this sounds a lot like kind of gap coverage to me. So there's a lot of like Medigap and things like that out there. So how do you differentiate yourself from that gap coverage, and how does that then, if that's an insurance and you're not, can you help me understand that?
One, we're relieving debt. So we're not paying out anything to anybody. We're actually providing the service. So we're not paying ourselves. We're not paying another air ambulance provider. So that's, we're not indemnifying ourselves in that sense. The next thing is we're not guaranteeing a service. We can't. There's no hard science to this industry. It's very unpredictable. You never know when a person may need the service. It could be an event that they may have caused themselves. They could be innocently driving down the road and get hit by another vehicle, and all of a sudden they need this service. The third thing is there's no reciprocity. So again, we're only covering ourselves. So it's a prepaid debt relief product for our members alone. So we have absolute control over it on the mechanisms that are internally inside of it. Where as an insurance product, if it was another company and we offered that, we would pay dues to that for those services rendered. We don't do that.
Thank you. Representative Frazier.
Thank you, Chairman. I just have a comment in regards to your concern. I think really, there's so few complaints because we have to remember there's only 0.1% of these policies that are ever being used. So to me, the no complaint issue is kind of like a red herring. It would be almost like buying a lottery ticket, not winning the lottery, and then complaining that you didn't win. So that's all how I'd like to respond to that.
Representative Bentley, if you're with us online, I think you have a question.
Thank you, Mr. Chairman. Here in rural Kentucky, up here in eastern Kentucky, sometimes we have trouble with the ambulances that are on the roads. My brother died of cardiac arrest because we couldn't get an ambulance to him within 20 minutes. So he died in his own residence. But I have a question for ARIVAC and to the nurse. My question is, being a medical provider myself, your ARIVAC helicopters, do they have all the ability of an emergency room except X-ray?
We are like a flying ICU or emergency room. I don't know that I would say that we have every ability that an emergency department has other than X-ray or radiology, but we do have all of the critical care drugs. We have a licensed critical care paramedic, critical care nurse, two caregivers taking care of the patient, one patient at a time. And we do have the cardiac monitors. We have the defibrillators, IV pumps, ventilators, all of those types of equipment that you would need for emergency resuscitation.
So that nurse is a certified critical care registered nurse, CCRN.
They are required to have an advanced certification. They might be a certified emergency nurse. They might be a critical care registered nurse. They might be a certified flight registered nurse. There's different certifications that you can get. But yes, they are all certified.
Can they warm an IV for an infant?
Yes, we have warm IV fluids.
Well, I think there is value in that helicopter then. It's similar to emergency room. It gets there quickly for the people in rural Kentucky, and it can warm an IV for an infant. That's a lot of care right there in one. What are those Bell helicopters? I think they are, that you all use. Yes. So I just wanted to show the value that helicopter is to the rural areas of Kentucky. Thank you, Mr. Chairman.
Thank you, Representative. Representative McPherson has a comment or a question.
Yes, it's more of a comment. I've sat here and kind of listened to all the pros and cons here. We've got a bill that's going into effect in 52 days. You've got 287,000 members that as long as we have full disclosure, it looks like the free market system will take care of itself. If you all don't provide the right product, and if everybody goes out with full disclosure and there's no need for this product, then you will go away. But if you don't, and people continue to buy it, then there's value in it. So it looks like to me that the fair market system is acting and will continue to act. Thank you, Mr. Chairman.
Thank you. And looks like the last question or comment this morning will come from Representative Lewis.
Thank you, Mr. Chairman. We have been working on this for quite some time. Chairman, several other members, we go to NCOIL quite often, have a great time, and really do important work with that. And so on this issue, I was under the same impression that Representative Meredith had, that, when the Surprise Billing Act passed, that a lot of these issues would be resolved. And I don't know. I guess I just take issue with how this is being approached. We've put a lot of effort, and in Incoil I actually offered an amendment myself to address a lot of these concerns. But best I can tell, we have one company who is pushing across the nation legislation that's going to impair their competitor's business model. And, as Representative Meredith said before, these are two very different models. And so I was just kind of glancing, doing some research while I was sitting here, and I see Air Methods discontinued membership services in 2009. So I guess that didn't work for them. GMR, they have 17 bases in Kentucky, one being in Clay County. And Clay County, this group is a community partner. You see the stickers on the back of vehicles. You see them sponsoring games. You don't hear volume of complaints, but no, you see these people as a community partner, and they work with their local hospitals. So going on, I kept researching, and I tried to find something about a patient in another state refusing care because it wasn't part of the service. Best I could tell, I couldn't find anything on that. But I did get on Air Methods website, and so I went around, and I came across a section that said membership deception, where they call their competitors money-making fraudsters. And so I guess I just take issue with using this legislative body to impair another private business, and I take issue with that. There's still a lot of issues out there, federal versus state, FAA control, great points made on both sides. But at the end of the day, government should not be picking winners and losers. Thank you, Mr. Chairman.
Thank you. Any other members seeking recognition on this topic or anything else this morning? Representative Frazier.
Yes, I would just like to comment, because I've heard it said many times, that you're relieving members of having to pay their own deductibles and co-pays. And to me, that's the definition of insurance. So, thank you.
Thank you. Well, I appreciate all of you being here this morning. This continues to be a very robust discussion, both here and at Incoil, and I know in other states. So I'm sure we will continue to talk about this issue and see how things evolve after in 52 days. And again, we thank you for your time. Thank you to the committee for your participation, and I will adjourn the meeting.